everyone. This will be the first of 3 PowerPoints that you will view to introduce you to the world of medical coding. The following PowerPoint will review several aspects of the medical coding process. First, we will discuss what coding is and why we do it. Next, we will learn about CPT codes. However, this will be reviewed again for further clarification and practice in Module 2. Next, we'll review ICD-10 codes, which are the main focus of this module. Finally, we'll review several case studies to help you practice ICD-10 coding. First things first, why do we code? Coding is used for reimbursement of time, skills, and services performed by medical staff. Payment for everything we do in the clinical setting is based on service and diagnostic codes. In order to bill, we must be reimbursed for the services provided. The services must be medically necessary, actually provided, documented correctly, and submitted. Providers cannot bill for the cost above the Medicare payment for services. Now we know why we do it, but what is it? Coding is the Center for Medicare and Medicaid Services guidelines to document patient services for the purpose of billing. Nurse practitioners are able to bill directly and receive reimbursement due to the Balanced Budget Act of 1997. NPs can bill with their own provider numbers and receive 85% of the allowable reimbursement amount. However, NPs can bill at the 100% rate if certain conditions of physician involvement are met. CPT codes, or current procedural terminology codes, are revised annually to reflect the most current practice. These CPT codes allow providers to bill for services performed in the clinic. A CPT code is just a 5-digit number attached to an action. These actions include the office visit, pulse oximetry, rapid flu test, EKGs, etc. Something to remember is that you cannot bill for something not performed in your office. An example of this is if you can run a CBC in your office, you can use the CPT code and bill for that CBC. But if you cannot run a CMP in the office, then you will need to send it out to the laboratory and the lab will bill for the CMP. In order to bill for a CPT code, the visit must be face-to-face, must be associated with an ICD-10 code, and documented appropriately. Now we will address how to code for office visits. There are 4 components to an office visit, including the chief complaint, history, exam, and medical decision making. Now remember, this will be more in depth in Module 2. The first is the chief complaint, which is the patient's presenting problem. The best way to document it is by using the patient's exact words. This is a representation of the established patient office codes. As you can see, a chief complaint is required for each of the following except 99211, which could be considered a nurse visit. The next component is the history. The first part of the history is the HPI, which is your old carts. The different HPI levels are based on elements. This chart is an example of how to determine how many elements you explored in the HPI. Did you ask about location, onset, and context? This would be 3 elements in an expanded problem-focused exam. The next aspect of the history is the review of systems. The review of systems must contain a certain amount of pertinent systems in order to be documented and billed correctly. Notice there are different levels to the review of systems. These levels are based on symptoms and elements addressed in these systems. Remember that other staff, such as MAs, can perform the review of systems, but the provider must review for accuracy. As you can see, this chart breaks down the systems. In order to be a comprehensive exam, at least 10 systems must be reviewed, but only 1 system needs to be reviewed in an expanded problem-focused. The next component of the history is your past medical, surgical, family, and social histories. Notice in this chart how the different levels of the office visit change based on the amount of information reviewed in the history. Here's a brief summary that explains how to determine the type of history you have obtained from the patient. The next aspect is the physical exam. Notice how this chart says that each type of exam must contain certain elements. These elements are not just your systems, but what you looked at in them. For example, if you examined the neck for bruit, palpated the thyroid, and examined range of motion, This would be 3 elements. Only the comprehensive exam is concerned with the number of systems. This chart is helpful to use to determine the number of elements and number of systems you reviewed. Let's review some examples of the different elements of the physical exam. On the left, you see an expanded problem-focused exam with a patient who reported cold symptoms. You examined the ears, nose, mouth, neck, heart, and lungs. But in these exams, you looked at multiple elements of each system. To be expanded problem-focused, you need 6 elements from any system. But to be detailed, you need 12 plus from 2 systems. You examined 10 elements. Therefore, this is an expanded problem-focused exam. The next patient you saw complained of fatigue, so you examined 9 different areas, 2 plus elements in each system. This would constitute this exam as comprehensive. Now, on to the final component of office visit coding, which is the medical decision making. There are several options for diagnosis, such as self-limited, stable, worsening, new with or without workup. This includes any diagnostics you ordered, such as labs, x-rays, colonoscopies, and the risk of the problem is also reviewed. This chart breaks this down and makes it easier to determine the level of decision making. Let's look at the moderate complexity of a 99213. This allows you to see a point system which you can determine the complexity of your medical decision making. This slide continues the medical decision-making process. This process will be reviewed further in Module 2 to clarify and expand on office coding. Finally, we can put all of that information together, the complexity, diagnostic and management options, and risk of complications. Now let's review our coding options. New patient CPT codes and established patient CPT codes are different, as new patients typically take more time than previously established patients. However, the principles of coding are the same. As you can see, the new patient codes range from problem-focused to comprehensive, as we have been reviewing. It is your job to determine, based on the chief complaint, history, exam, and medical decision-making, what the code for this patient is. Here are the established patient codes. These codes go from problem-focused to comprehensive as well. You will see on the left side where it says nurse visit. These visits are typically coded when the patient is coming in for labs or a vaccination and the provider does not need to see the patient. There's a third way to code for office visits, and this is based on the amount of time spent. However, you can only code based on time if greater than 50% of the office visit time is spent counseling the patient. You must document thoroughly that you spent X amount of time counseling in order to code for this visit. Here's an excellent example of a pocket guide used for office visit coding. You will be provided this as a PDF in Module 2. Now that we have done a brief overview of CPT codes, let's take a minute to discuss diagnostic codes. The International Classification of Disease 10th Revision, or ICD-10, is a classification published for the U.S. to classify diagnoses in the healthcare setting. They are based on classifications published by the World Health Organization. Each ICD-10 code starts with a letter and is followed by 3 to 6 other characters. These codes should be reported at their highest number of characters. You can only use a 3-character code if it cannot be broken down or classified any further. Here's an example of an ICD-10 code. As you can see, they are 3 to 7 characters long. The first 3 characters represent the category that the disease process is in, and the following characters are the period present, the etiology, the anatomic position, or severity. An X is sometimes used as a place setting for future expansion of the code. There are some general guidelines when using ICD-10 codes. Signs and symptoms such as fever, fatigue, and cough can only be used when other diagnosis has not been confirmed. Once a diagnosis is made, then the ICD-10 code should change to reflect that. If the patient has a disease such as COPD, then the symptom of a cough should not be assigned, since this is normally associated with the disease process. If the patient is having an acute exacerbation of a chronic condition, then always chart both the acute and the chronic condition. but place the acute first as this is the highest order of importance. You can code certain assignments from nurses or MAs assessments and document in the medical record. This would be things like the BMI. Please remember that every diagnosis you give a patient is on their medical record forever, so do not bill for a code unless you are 100% sure that they have that condition. For example, if a patient reports with one high blood pressure reading, you cannot diagnose them with hypertension. You must follow the diagnostic guidelines for this condition. Let's apply this knowledge you've just learned. You have a patient with otitis media that you want to code a diagnosis for. So you go to the chapter on diseases of the ear, which is H60 to H95. Do you see where that initial 3-character sequence comes from? Your diagnosis is non-suppurative otitis media, so you pick the H65 chapter. It is an acute serous otitis media, so this would be H65.0, but now you have to pick the anatomical position. Is it left, right, or bilateral? Your diagnosis is for a right-sided otitis media, so you code for H65.01. Let's try this again with hypertension. You need to go to the chapters on diseases of the circulatory system, so you go I00 to I99. You know it is a hypertensive disease, so you go to I10. Now notice that this is only 3 characters. This is because essential primary hypertension cannot be broken down further into anatomical site or etiology. Let's do some more examples. You have a patient come in for a wellness visit, so you know that is under the chapter on persons encounter for health services. This is the Z00 chapter, and it is a general adult medical exam, so now you have Z00.0. There are no abnormal findings, and you must document this. So now you have a Z00.00. Let's look at this 4th example. You have a patient come in for exposure to chlamydia, so this would yet again be under the chapter where the patient is in contact with health service. But this time we must go under the potential health hazards of communicable diseases. So this is a Z20 diagnosis. But we have to break it down further because the etiology is exposure to a disease with sexual transmission, which is Z20.2. Notice that is not a chlamydia diagnosis. We have to test and make 100% sure that this patient actually has a diagnosis of chlamydia before assigning that diagnosis to their medical record. If the patient's testing does come back positive, then this will be changed and updated on the medical record to reflect the most appropriate code. ICD-10 codes can seem a little overwhelming when starting out because there's a code for everything. Now that you've learned what coding is, why we code, and how we code, let's look at how we chart in Typhon. First, add a new case log. Next, choose the date. I always suggest charting on the day of. On the top right of the screen, click the notepad-looking box under the ICD-10 Diagnosis Codes section. This will pull up a means to search a diagnosis by name. So let's look at otitis media, which brought up way too many answers for me to read through. So let's try a different method. Go back to the main screen where you'll be charting and click the magnifying glass that was next to the notepad. I used the pull-down tab and found diseases of the ear and mastoid. I used the third tab down to find non-suppurative otitis media. Next, I chose acute serous otitis media. And finally, used the last tab to find which ear and if it was recurrent or not. That led me to a diagnosis code of H65.02, acute serous otitis media of the left ear. Now that you've learned how to look up codes, we're going to practice diagnostic and coding skills. You have an 8-year-old female who presents to the clinic today with reports of a sore throat. Her mother reports that she began complaining of a sore throat 2 days ago, and she developed a fever last night with a temperature of 102. Her mother reports that Tylenol helped decrease her temperature to 100. She has not had Tylenol this morning. She reports that her daughter has also complained of her stomach hurting and nausea, but has not vomited. She's allergic to latex and tree pollen. She's currently taking Allegra. She has seasonal allergies, and she has a history of tympanostomy tubes. No headaches, runny nose, swollen lymph nodes, and she has a sore throat. No cough. She reports abdominal pain and nausea. No rash, no muscle. Her vital signs are stable except for her temperature is 101.4. The patient is a white female who appears to be in no acute distress. The only issues on her exam were that her tonsils are 2+, they're erythematous, and have white to yellow exudate. Her submandibular lymph nodes are swollen and tender upon palpation. What diagnostic tool would you use to help diagnose this patient's condition? What are your differentials based on history and assessment? What other information do you need? So we ran a strep test and it came back positive. What is your diagnosis? Streptococcal pharyngitis, acute pharyngitis due to other specified organisms, or acute pharyngitis? Now use your resources and find the appropriate diagnosis code. We'll discuss CPT codes in Module 2. Streptococcal pharyngitis is the best diagnosis for this patient, and that code is J02.0. Let's try another one. You have a 52-year-old male who comes into the clinic with reports that he got into poison ivy 2 days ago. He noticed the rash began to form yesterday, and it's on his hands and has spread and become worse. He says he's had a reaction like this in the past, and he's been using hydrocortisone 1%, but it hasn't helped and he's still itching. He's got a history of allergies to poison ivy and penicillin. He had an appendectomy but no other history. He hasn't had any labs, and he hasn't had a wellness visit in a year. He doesn't have a runny nose, no wheezing, no shortness of breath, no chest pain. He does have a red, weeping, itchy rash on his forearms and hands. He is considered obese, but other than that, everything's stable. He's a 52-year-old white male who appears to be in no acute distress. His conjunctiva are pink, nasal mucosa are pink, oropharynx is pink, regular rate and rhythm, lungs are clear to auscultation. He does have numerous vesicular lesions on an erythematous base without weeping and no open vesicles noted on his hands and forearms. Notice the pattern on this patient. Think about how you would describe that when you're charting. What are your differential diagnoses for this patient? What do you think the diagnosis for this patient is? Use your resources and find the appropriate diagnosis code. L23.7, allergic contact dermatitis due to plants except food. Notice how you have to break this one down into the etiology and not the location. This is the final case study. A 65-year-old African-American male presents to the clinic for a routine follow-up visit. He's here for his diabetes, mixed hyperlipidemia, and obesity. He does not have an increase in drinking or urination, no numbness or tingling. He had his eye exam 2 months ago, no ulcers. He's been wearing his diabetic shoes. He's not been following his diet, and he's taking his metformin without complaints. He's taking his pravastatin without complaints, and he has not been attempting to lose weight. So no known drug allergies. He's on metformin and pravastatin, and that's it. He has diabetes, hyperlipidemia, obesity, and he had a tonsillectomy. He's never smoked, never used alcohol, never used drugs. Here is his review of systems. Vital signs are okay. His blood pressure is 155/80 though, and he is considered obese. We have an African American male who appears as stated age and is in no acute distress. HEENT is good, respiratory is good, cardiac's good. He does have a rounded abdomen. He's got full range of motion in upper and lower extremities. He does have dry skin. We did perform a diabetic foot exam without concern, and then neuro, we are not concerned. What labs would you order for this patient? What other instructions should you give the patient based on their assessment? When do you think the patient should follow up? What other wellness education should you provide this patient? What diagnosis code would you give this patient? Remember, there are several issues going on with the patient, so look up all of the diagnosis codes you can think of. Also, remember, you have to be 100% sure of the diagnosis before assigning it to the patient. Diabetes, hyperlipidemia, obesity, and elevated blood pressure reading without diagnosis of hypertension. He was not given the I-10 diagnosis code for hypertension, but he has high blood pressure at this visit. He has not met the full diagnostic criteria, so we suggest that the patient keep a blood pressure diary and return for follow-up in 1 week. If his blood pressure meets the criteria for diagnosis, then we can update his chart to reflect a hypertension diagnosis. So the patient returns in 1 week for follow-up with a blood pressure log that reflects the following. Does he now meet the criteria for hypertension? Here's his laboratory data from the previous visit for you to review with the patient. What do you notice about this data? Which elements are concerning for you? His UA shows some protein, his cholesterol is elevated, his fasting blood sugar is elevated, and his A1C is elevated. What would you address after reviewing this patient's labs, blood pressure log, and using the information about the patient's lifestyle from the previous visit? What is the new diagnosis code for the patient? How do you code this visit? Essential primary hypertension, diabetes, hyperlipidemia, and obesity. We would code this because we yet again addressed all of these issues. Thank you for joining me for Module 1, an introduction to medical coding. There will be 2 more modules to address coding in the office setting. Module 2 will focus on CPT coding, and Module 3 will focus on preventative care. Thank you. Module 2, CPT coding expanded. A lot of this material you will remember from Module 1, however, due to the nature and difficulty of CPT coding, it will be reviewed again. In this module, we will reevaluate what CPT coding is, the evaluation and management aspect, key components of the office visit, and lastly, case studies. If you'll remember from Module 1, CPT codes allow for reimbursement of a service that is performed at the clinic. These services are based on a value scale that is based on work done, expense, liability, insurance, and geographic location. In order to bill for a certain CPT code, documentation must reflect the service performed. The CPT code is a 5-digit number that is attached to an action such as the office visit, counseling for smoking cessation, certain screening tools, laboratory testing, and more. Remember that you cannot bill for labs that were not performed in your office. If you are having to send out a CBC, then you cannot bill for it. If you are having to refer a patient for an x-ray, then you cannot bill for performance of the x-ray. However, if you run a urinalysis in the office, you can bill for that. If you have the capability to run a CBC in the office, then you can bill for that too. In order to bill for a CPT code, the interaction must be face-to-face with the provider and patient. You have to associate each CPT code with an ICD-10 code. For example, you would like to run a CBC, then you must have a diagnosis code with it. You could use the ICD-10 code for hypertension, which is I-10, and then order a CBC, or you could attach E11.9, which is type 2 diabetes, and run an A1C. The level of service for your billing is determined by the extent and complexity of the key components. In order to bill for something, you must document it. For example, you cannot bill for smoking cessation counseling if you do not document that you counseled the patient on smoking cessation. If you remember from Module 1, we discussed 4 key components of office visit coding. These include the chief complaint, history, exam, medical decision-making. The following information should look very familiar to you. We will be reviewing CPT codes yet again for clarification. The chief complaint is the statement for why the patient has presented to the clinic. You should chart this in the patient's words and make sure that it is documented appropriately. The next component is the history. This includes a variety of aspects of the patient's medical, social, and personal history. The first to note is the history of presenting illness. This is typically when you would use your old charts and search for the information that will point you in the direction of the patient's concern. The different office visit levels are determined by the number of elements you reviewed with this patient. Sometimes the old charts method is not the best way to review a patient's history of presenting illness. As you can see in the detailed section, this addresses chronic diseases that the patient currently has. For example, an expanded problem-focused exam would focus more on old carts to determine the patient's recent upper respiratory symptoms, but a detailed exam would focus more on questions about the patient's chronic condition, like how they are taking their medications, any concerns they might have, and of course any physical or mental symptoms they would be experiencing. The next component to the patient's history is the past medical, surgical, family, social, and potentially personal history of the patient. During a nurse visit for a vaccine, it would not be pertinent to ask about family history, so this would be a 99212 code. However, if you are to perform a detailed or comprehensive exam, then these aspects of the patient's history would be pertinent. Allergies and history of tobacco use are almost always pertinent when obtaining a history on a patient, but if the patient presents for strep throat, it might not be pertinent to ask about family history. Likewise, if this patient reports chest pain, then a family history would be pertinent. This is where it is important to understand your disease processes and to understand the importance of the different components of the history. If you're having a difficult time determining what level you should code based on what you have done, charts like these are an excellent example to benefit your practice. This chart and others like it will be found later in Module 2 for you to have access. The next component of the history is a review of systems. This is an overview of the patient's symptoms. It is a subjective report from the patient and is useful to narrow down what differential diagnosis you have for the patient. Remember that MAs and nurses can perform the ROS, but you need to review it for accuracy. This is an essential component of your patient encounter, so make sure to review it thoroughly as it will help guide your diagnosis. This chart will help you as you begin your CPT coding process. The review of systems focuses on systems that you have addressed. Here's a summary of the review of the history aspect of charting that we just went over. You will be provided with resources to print, copy, scan, and bring with you later in Module 2. The next part of the 4 key components is the physical exam. The way you establish your level of coding with the exam is through the number of elements you addressed and not the number of systems you addressed. It is a problem-focused exam if you only examined a limited body area or organ system. The expanded problem focus must have the affected body area assessed plus other symptomatic organs. The detailed exam needs an extended exam of the affected organ plus other symptomatic body parts. The comprehensive exam requires at least 9 body systems to be examined with at least 2 elements in each system. These elements can be confusing, so using a chart like this one as you start the coding process will assist you in deciding what type of exam you performed. As we reviewed in Module 1, let us review the difference between the elements again. A person comes in with cold symptoms, so you briefly examine their ears, nose, mouth, neck, heart, and lungs. You have examined multiple body systems, but you have examined only 10 elements in the systems total, making this an expanded problem-focused exam. To be a detailed exam, you would need more information, but to be a problem-focused exam, you would need less information. Now looking at the second example, you have a patient come in with fatigue. The vague nature of fatigue as a chief complaint warrants a thorough assessment of many body systems as this could be a symptom related to the endocrine system, the circulatory system, the respiratory system, or even the neurological system. So a large array of systems need to be reviewed. In this instance, you reviewed 9 body systems and looked at 2 different elements in each of these systems. For example, you examined the neck, but looked at both the thyroid and the lymph nodes. You examined the respiratory system, but you looked at for lung sounds, but also the AP diameter. So you've assessed multiple body systems, but also multiple aspects of each of these body systems. Moving on to the medical decision-making component of office visit coding, there are several diagnosis and management options. The problem you diagnose could be self-limiting, like a viral infection, or an established problem that is stable, like high blood pressure. You could have an established problem that is getting worse, such as a patient with type 2 diabetes whose A1C went from 9% 3 months ago to 12% this visit. You could have a patient with a new problem that needs no additional workup, such as strep throat, or you could have a patient who comes in with a mass in their breast and they're in need of a mammogram. Other things to consider in the medical decision-making process is if you had to do anything else for this patient, such as order and review labs, perform an x-ray, or order other diagnostics tests such as like an ultrasound or a CT scan. You must also consider the risk of the diagnosis. The diagnosis of an upper respiratory infection is not as much risk as a diagnosis of COPD because of the complexity of treatment. Using this chart to assist you will be very helpful. As you can see, there are many different components to the medical decision-making process, and having a chart like this will definitely assist you as you begin the process and learn what aspects make up each level of coding. Here's that chart continued. reviewed, and remember you will have this later on in Module 2. This is a summary of the medical decision-making process. It shows how the different levels are chosen based on the number of management options, the complexity of the data, and the risk for complication. The hard part, now you just have to figure out how to pull it all together. Remember how in Module 1 we mentioned that new patient and established patient coding are different? See how the levels of care have different numbers? These basically mean the same thing as an established visit would, but the coding is different due to the increased time spent with new patients. New patient coding follows the same rules and is evaluated based on history, exam, and medical decision making, but the numbers are different for the final coding process, so make sure to pay close attention to this. This is just a summary of the established office visit coding. The majority of the time you will be using one of these codes, but always remember if it is a new patient or preventative visit, then these codes will be different. Time is a factor for coding only when greater than 50% of the time is spent in the visit for counseling. So if the provider counsels the patient on smoking cessation for 20 minutes out of a 30-minute visit, then they would be able to code based on time instead of complexity, risk, and exam type. This provider would also be able to use the CPT code to bill for smoking cessation counseling. If the provider decides to bill based on the time spent in the room counseling the patient, they need to make sure that there's adequate documentation on the time spent and the counseling done with the patient in order to bill based on time. Let's work on some case studies. You saw case 1 and 2 in Module 1, but now we'll look at these from a different viewpoint. You have an established patient who is an 8-year-old female who presents to the clinic today with a sore throat for 2 days. Her mother says that she began complaining of a sore throat 2 days ago. She developed a fever last night with a temp of 102. Her mother reports that Tylenol helped decrease her temperature to 100, and she has not had any Tylenol this morning. She reports that her daughter has also been complaining that her stomach hurts. She has been nauseous since last night, but has not vomited. She does not have a headache, rash, swollen lymph nodes, diarrhea, cough, runny nose, or muscle aches. She's allergic to latex and tree pollen, and she's currently taking Allegra. Her ROS, no headaches, runny nose, swollen lymph nodes, but she reports a sore throat, no cough, reports abdominal pain, and nausea. Her vital signs: temp 101.4, O2 98%, heart rate 98, respiratory rate 18, blood pressure 90/17. She is 4 foot 4 inches and 52 pounds, which is an ideal weight for her. Okay, so she's a white female who appears to be in no acute distress. Her tympanic membranes are pearly gray and intact. She has pink mucosa with clear drainage. Tonsils are 2+, erythematous, and with white to yellow exudate. Her submandibular lymph nodes are swollen and tender upon palpation. Lungs are clear. Heart rate is regular, and rhythm is regular. Bowel sounds are present and active. No mass is noted. The last time we decided to run a strep test based on this patient's clinical presentation. Same thing in this case. Test was positive. Now remember for screenings like this that you must see the control line, otherwise the test is not accurate. We diagnosed the patient with strep throat. So now let's look at what all we have done to determine the CPT code for this patient visit. Back at our history to determine what we've done. So we reviewed allergies in case we need to give her any medications, and we reviewed her medications. We reviewed HEENT, respiratory, and GI systems. If complaint is present, we assessed onset, alleviating factors, and associated symptoms, making this a brief HPI. Our ROS focused on HEENT, respiratory, and GI systems, so that would be considered a detailed ROS. But we did not review any of the past medical history except for allergies and current medications. Here's our physical exam again. We looked at the general: ears, nose, throat, lymph nodes, lungs, heart, bowel sounds, abdominal tenderness, and skin. Exam, we assessed 10 different elements for several different systems. This places us in the expanded problem-focused section. Let's determine the medical decision-making process. The number of options was limited, the complexity of the data was low, and the risk of complication is low. So this puts this encounter into the low complexity category. Based on the history, the exam, and the medical decision-making process, this would be coded as a 99213 or expanded problem-focused patient encounter. Here's a pocket guide that can be taken with you to clinical to assist in your decision-making process. You will be given this later in Module 2 to assist in your clinical setting. And 99213 plus the CPT code for the rapid strep test that was performed in the office. Moving on to case study 2, this is a new patient. He's a 52-year-old male who works in landscaping, and he came into the clinic reporting that he got into poison ivy 2 days ago. He reports that he was exposed to poison ivy. He noticed the rash began to form yesterday on his hands, and now it has spread and become much worse. It is now located on both hands and forearms. He reports that he has had a reaction in the past that was similar to this instance. He's been using hydrocortisone 1%, but it has not helped, and he is itching. Patient denies having the rash anywhere else. So he has a history of poison ivy allergy, allergies to penicillin, and he is currently using hydrocortisone 1% cream, but nothing else. His review system shows no runny nose, no change in vision, no sore throat, no wheezing or coughing, no shortness of breath, palpitations, chest tightness. He has a red, weeping, itchy rash on bilateral forearms and hands. His vital signs are stable. BMI, he is obese. So we have a 52-year-old white male who appears to be in no acute distress. His conjunctiva are pink. Nasal mucosa is pink without drainage. Pharynx is pink without edema, no tenderness or swelling of lymph nodes. Regular rate and rhythm of his heart. Lungs are clear to auscultation. Skin, of his bilateral hands and forearms are covered in numerous vesicular lesions on an erythematous base. No weeping is present and no open vesicles noted. Remember this image in your diagnosis? Code for that. We had a chief complaint, a brief HPI, and a problem pertinent review of systems. For the exam, we assessed 8 different elements, making this an expanded problem-focused assessment. As evaluation and management go, this is straightforward. There are minimal diagnostic options, little complexity, and at minimal risk for complication. This was a new patient, so he needs the new patient coding for 99202. The codes for this patient encounter are 99202 for the new patient office visit and a 94760 for the pulse oximetry reading. Okay, so case study 3, we have an established patient who is a 32-year-old female who comes in with complaints of fatigue. She says the fatigue began about 2 months ago. She's not currently taking any medications, and she has not had any recent illnesses or surgeries. She reports that she'll go to bed at 9 and wake up at 6 and still feel tired. She reports that she only drinks coffee in the morning. She turns her TV off 1 hour before bed. No reports of fever, headache, blurred vision, edema, shortness of breath, palpitations, snoring, or diarrhea. Patient reports fatigue, a recent weight gain of 15 pounds, hair loss, dry skin, and constipation. Patient reports that for the past 2 months her periods have been regular but heavy. Denies exposure to TB, recent foreign travel, or spending time in the woods. She has no known drug allergies, not on any medications. She is a G1P1 with a C-section in 2015 with no other history. No tobacco, drug, or alcohol use. Her mother has a history of hypothyroid. Her father has a history of diabetes, and her maternal grandmother has a history of stroke. She had her pap smear back in 2016, and last time she had laboratory work was 2016. She reports fatigue, weight gain, but denies fever. No headaches, blurred vision, sore throat, runny nose. She reports hair loss. No edema or palpitations. No shortness of breath or reports of snoring. No reports of diarrhea. She reports constipation, though. She reports dry skin. No swollen or painful joints. No neck or back pain. She reports irregular, heavy periods. And no thoughts to harm herself or others. we're going to use the PHQ-2 scale, the Epworth Sleepiness Scale, and the Partner Violence Screen. Her vital signs are all stable. She's a little bit overweight, but she's not in any pain. Alright, so we have a 32-year-old African American female who appears to be in no acute distress. She does have thinning hair. Her conjunctiva are pink. Her nasal mucosa is pink without drainage. Her pharynx is pink. No tenderness or swelling of the lymph nodes. Thyroid is not palpable, and no bruit is noted. She has a regular rate and rhythm with no edema. Her lungs are clear to auscultation. Her bowel sounds are hypoactive. There's no rashes or lesions on her, but she does have some generalized dryness. She has full range of motion of upper and lower extremities. She's alert and oriented ×3, and mood is appropriate for situation. So we are going to get these labs on her. A urinalysis, a CBC with diff, a CMP, TSH, T4, hemoglobin A1C, and a vitamin D on her. Her diagnosis is fatigue because we don't have anything definitive right now. And you can code the patient's symptoms at this point until you get a definitive diagnosis. Based on the history, this is a detailed exam. The chief complaint was present, there was an extended HPI, the review of systems was extended, and the past medical history, family history, social history was pertinent. Systems reviewed, but not more than 9, so this would fall under a detailed exam. Complexity in this case is moderate, as there are many potential diagnoses with different management options. The complexity of data is moderate, and the risk is moderate. This would be considered a 99214. Very rarely are you ever going to code a 99215. Here's your pocket guide. Office visit coding is going to be a 99214. The UA is a 81001. Venipuncture is a 36415, and pulse oximetry is a 94760. We did not code the other labs that we ordered. This is because we sent these labs off to be performed, and so the lab will code them for us. Thank you. Hey everyone, this is your third and final coding module. Today we'll be focusing on preventative care coding. We will begin by discussing the basics of preventative care coding, followed by adult wellness, women's wellness, men's wellness, and then pediatric preventative care. We will finish this module with 3 case studies. First, let's review the basics. Step is to determine if the patient is new or established. Next, during your exam, if you note an abnormality or address a pre-existing condition, then you would code for both the preventative care plus the code for the appropriate office visit. This means you would use the annual wellness CPT code plus your 99213 code. Now what you need to educate your patient on is the fact that adding this problem visit will then add a copay to their preventative visit. The other option is to request that the patient return in a week to address the problem. ICD-10 codes for preventative care are fairly straightforward, but preventative coding is still complicated. To make sure that the insurance company pays for the care, you must properly code the combination of CPT codes and ICD-10 codes. Insurance will cover for a wellness visit 1 year and 1 day after the last visit. These are all aspects of the general wellness visit. Screening tools including depression, vital signs, height, weight, BMI, vaccines, advanced directives, updating history, updating medications, personal health advice, risk factor education, anticipatory guidance, labs, and other diagnostics. A wellness visit is not a problem visit. However, CPT instructs if an abnormality is encountered or a pre-existing problem is addressed in the process of performing this preventative medicine evaluation and management service, and if the problem or abnormality is significant enough to require additional work to perform the key components of a problem-oriented evaluation management service, then the appropriate office outpatient code 99201 through 99215 should also be reported. Coding for vaccines. When coding for vaccinations, you simply report the ICD-10 code Z23. Z23 is the ICD-10 code for encounter for immunization. This covers every vaccine, no matter how many vaccines were given or what the vaccine was. Now, you also have to assign the CPT code for giving the vaccine plus the specific vaccine that you gave. Age-specific or non-age specific. These are the codes for non-age specific immunization coding. As you can see, 90471 covers your percutaneous, intradermal, sub-Q, or IM injections, and then 90472 is each additional vaccine you gave. 90473 covers intranasal or oral, and then 90474 is each additional of those intranasal or oral vaccines. This slide focuses on pediatric immunizations or age-specific immunization coding. So you'll see here it says immunization administration through 18 years of age via any route by qualified healthcare professional, first or only component of each vaccine. Component refers to all antigens in a vaccine that prevent diseases caused by one organism. Combination vaccines contain multiple components. Report a 90460 for the first or only component in a single vaccine. You can chart 90460 multiple times per encounter. 90461 is an add-on only to 90460 if there are more than one component to the vaccine. You can only use these codes if the patient is 18 or younger and when counseling about the vaccine has been given. Sometimes immunizations are not given during routine preventative services. Due to tracking purposes and quality measures, it is important to report non-administered vaccines. Here would be the ICD-10 codes for the reason that the vaccine was not given. This information will be provided to you later in the module. Remember, when you code a vaccine, you have to code the immunization code plus the vaccine code plus the encounter for immunization ICD-10 code. Now that we reviewed some general guidelines for preventative care, let's review an adult preventative care visit. For an annual visit, you really should not have a chief complaint or HPI. You can briefly address the patient's current problems, but for additional interventions, you would need to add on a problem visit CPT code for insurance to pay for this. This would mean the patient would have to have a copay. So in an adult preventative care visit, you update a history, evaluate based on age and history, you do a physical exam, advice, screening, labs, diagnostics. Additional screenings would include an obesity screening, STI screening and counseling, depression screen, cholesterol screen, lung cancer, skin cancer, and a discussion about vision and dental exams. There are several labs that are considered always diagnostic in the general adult population that will not be covered in a preventative visit. These include a CBC, a CMP, and a urinalysis. National guidelines have recently changed, stating that a PSA should only be used as a diagnostic tool if there's a problem. It's no longer considered a screening. These are the recommended vaccines for adults, including the ages at which they are recommended. During the adult wellness visit, we need to screen and provide counseling as well as anticipatory guidance on aging. So we should screen for depression, obesity, tobacco, alcohol, substance abuse, pregnancy. We should screen for fall risk, injury, domestic violence, seatbelt use. And we need to review the medications, and then we need to discuss advanced directives with each patient. You should not bill additionally for counseling during a routine wellness visit, as this is considered part of the preventative care visit. However, during an acute visit, you can also use preventative coding to counsel patients. For example, if a patient comes in for an ankle sprain and you address tobacco cessation, then you could code for a preventative medicine code. Now remember that these codes include all of the following in them, so do not bill separately: history, exam, counseling, guidance, risk reduction, interventions. You can bill for immunizations as well as appropriate screening tools, but remember, insurance will not pay for it as part of a preventative care visit if the diagnostic is not considered part of the routine screening. Now let's review women's preventative care. Since over half of all pregnancies in the United States are unplanned, preconception counseling should occur at each wellness visit. Make sure to update vaccines as needed for women who plan to become pregnant. This includes Hep B, MMR, influenza, and Tdap. The idea of preconception care in the annual wellness visit is to address issues that are concerning in case of pregnancy. These are typically issues that should be addressed in an annual exam anyway, such as potential risk for mother and fetus, education and risk and counseling options for these risks, and initiating interventions to assist in care such as vaccinations and folic acid. Other screening tools to note in women are the BRCA risk assessment and genetic counseling if at high risk. Intimate partner violence should be assessed annually. Contraceptive counseling is part of the Well Woman exam. However, it is important to note that some insurance companies will not cover contraceptive counseling due to religious beliefs. During Well Woman visits, women of childbearing age should be counseled on folic acid supplementation. Cholesterol should be screened in women 20 to 45 who are at increased risk of CHD, and women who are 45 plus should be screened if they are at risk of CHD. Women aged 20 years and older who are not at risk for coronary heart disease should not be screened. This is considered a C category in the USPSTF clinical recommendations for cholesterol screening. According to USPSTF, anemia screenings are only recommended as routine screening in asymptomatic pregnant women, but not women who are not pregnant. This would be coded under the Z130, encounter for screening for diseases of the blood and blood-forming organs and certain disorders involving the immune mechanism. Remember how it was previously mentioned that a urinalysis was not considered a screening tool? Well, in pregnant women and all women of childbearing age, a urinalysis is considered a screening tool if coded with a preventative visit code. This is where preventative care gets confusing, as some codes are not considered screening unless you are a woman of childbearing age or pregnant. These are the preventative codes for Well Woman exams. Remember that insurance might not pay for certain screenings past certain ages, so it is up to you as a provider to determine how to code STI screenings of women over 25. These codes are linked with or without a pap smear. During routine Well Woman exams, you should screen all sexually active women under the age of 25 for STIs annually, and women older than 25 should be screened if they are at risk, such as a new partner, multiple partners, or other risky health behaviors. These are the ICD-10 codes for contraceptive management. This list is not comprehensive and does not include long-acting reversible contraceptives. You will be given the comprehensive list later in Module 3. You can code these ICD-10 codes during your preventative care visit, as contraceptive counseling is considered to be part of the wellness visit. You follow the same CPT coding guidelines for any general adult wellness exam. Now let's discuss men's preventative care. These are the screening recommendations for men over the age of 18. We are no longer screening for prostate cancer routinely, as the PSA can often show false results. Men should now only be tested if there is an issue or problem occurring, as this is now considered a diagnostic instead of a screening tool. Other screens should be cholesterol, abdominal aortic aneurysm, and that's only if they have smoked and they are between the ages of 65 and 75. Now let's discuss pediatric preventative care. These wellness visits can occur at more frequent intervals due to the rapid growth in children, especially in the first few years of life, so you should follow the appropriate guidelines. Pediatric preventative care includes screening tools for depression and autism, vital signs, height, weight, BMI, head circumference, vaccines, history, medications, risk factors, definitely anticipatory guidance, and some labs. This is the Bright Futures Screening and Preventative Care Guidelines for Pediatrics. You'll be given the full form later in Module 3 to assist in your pediatric care. This is a comprehensive list that explains what to screen and examine for peds in their preventative care visits. This is the list of the pediatric immunizations. These are the CPT and ICD-10 codes to follow when billing for a pediatric wellness visit. Notice that the codes are determined by the age of the patient. So a 99381 is the CPT code for an infant younger than 1, but then a 99384 is for an adolescent between 12 and 17. You also have Z00.110, which is for newborns under 8 days old, but then the Z00121 and Z00129 are for kids 1 through 17. As an adult health, remember that sometimes immunizations are not given for certain reasons. So it is important to code for the reason that the patient is not being vaccinated, especially in the pediatric population. While a sports physical is considered a preventative service, a provider cannot bill one of the preventative services CPT codes for a sports physical because they are not considered comprehensive. That being said, an insurance company might not pay for a sports physical under a 99212 to 99215 because these are often considered problem visits. The best suggestion would be to perform sports physicals during the annual wellness visit in which a comprehensive exam is performed. Now we will test your knowledge with several case studies. You have a 21-year-old female who presents for her well woman exam. She's currently on low estrogen FE without complaints. Her last menstrual period was 6 years ago when she started her oral contraceptive. She is satisfied with this contraceptive method and has no complaints. She's a G0, P0 and reports one male partner. No complaints. She's allergic to penicillin. She's on low estrogen FE and a multivitamin. Menarche began at 12. No significant past medical history. She has a history of migraines in her family, lung cancer, heart attack, diabetes, hypertension, and cyst. She denies tobacco, drug use, and reports 2 to 3 drinks of alcohol 2 to 3 days per week. She denies a history of STIs or PID. She has no desire for pregnancy right now. She gets about 1 hour of cardio 3 days per week. She denies breast masses, lesions, rashes, or discharge, denies pelvic pain, bleeding, vaginal discharge, dryness, lesions, burning, and denies concerns of sexual dysfunction. She denies dysuria, hematuria, nocturia, flank pain or retention. She denies blood and stool, constipation, pain with defecation, diarrhea, nausea, or vomiting, and she denies thoughts of suicide. She is underweight. Her vital signs are she's a white female who appears her stated age and is in no acute distress. Her lungs are clear to auscultation. She has a regular rate and rhythm. She has no masses, lesions, or tenderness or discharge noted on bilateral breast. No CVA tenderness. No concerns with the rest of her exam. So what laboratory data and other screening methods do you need for this visit? And what counseling would you need for this visit? So you need to do a urinalysis since she is a woman of reproductive age. You need to check her blood pressure, perform her first pap smear, perform a chlamydia gonorrhea screen since she's under 25. You need to discuss and offer HIV screening, and you need to screen for partner violence. Remember that the general adult preventative care, a urinalysis is not a screening tool, but because she is a female of childbearing age, she would be screened with a urinalysis. What would your ICD-10 diagnosis codes be for this visit? What would your CPT codes be? So this is a encounter for gynecological examination. That includes the pap smear in there. Encounter for screening for sexual STIs. Encounter for surveillance of oral contraceptives, and then you can screen for her or code for her BMI. This would be considered a preventative care visit, and then you'd bill for the urinalysis as well. Everything else the lab would bill for because they are doing the pap smear, they are doing the labs on the pap smear, they're doing the labs on the STI testing. So you have a 54-year-old male who presents with complaints of heartburn for 2 weeks. He began experiencing the heartburn 2 weeks ago and it is constant, 3 out of 10 pain in his mid-abdomen. The burning goes up to his neck. He reports a sour taste in his mouth, is burping, and sleeps on 3 pillows. He says he's in constant pain but gets worse after he eats spicy food, gets better with dairy, denies increased pain after eating. He reports that he takes Tums and it only helps for a few minutes. He does have a history of GERD and reports that it got better after he lost 30 pounds, but it's come back. He reports that he's a 2-pack per day smoker and started when he was 12 years old. He has no known drug allergies. He's currently on lisinopril and pravastatin. He has a history of hypertension, hyperlipidemia, GERD, and no surgical history. He denies alcohol, drug use, and he has the 2-pack per day tobacco use. No headaches, fatigue, weight loss, night sweats, no edema, palpitations, or syncope, no shortness of breath or wheezing. He has heartburn, no blood in stool, constipation, diarrhea, nausea, vomiting, or abdominal pain. He is considered obese. His vital signs are stable. Appears to be older than his stated age. He's in no acute distress. His lungs are clear. His heart rate is regular. He has no murmurs. He has bowel sounds active and present in all 4 quadrants. No bruise, no splenomegaly, hepatomegaly, no tenderness, no CVA tenderness, and skin is. The patient is diagnosed with GERD and given omeprazole for his symptoms. What counseling would benefit this patient to reduce his symptoms? What are the ICD-10 and CPT codes for this office visit? The symptoms of GERD can be triggered by tobacco use as well as obesity. You need to counsel this patient on tobacco cessation as well as dietary changes and weight loss. But remember, in order to code for them, you must accurately and specifically document what you counseled on, as well as the time you spent in order to bill for counseling. Because this is just a case study, we're going to assume some things about this diagnosis and assume it's GERD. Notice the CPT code is for a problem visit. This exercise is to show you how preventative care can be coded in a problem visit. This patient needs to be educated about tobacco cessation in order to help most of his problems. Notice that only tobacco use cessation is coded on this. You need to educate the patient on tobacco cessation, document this appropriately, as well as document the time needed. You should also suggest that this patient return to discuss diet and exercise for weight loss. However, given a 15-minute office visit slot with this patient, it's difficult to provide education and counseling on multiple things. You have an 11-year-old female patient who presents with a need for a sports physical and an earache in her left ear. She says that she's going to start playing volleyball this year and that she had pain in her left ear beginning 3 days ago. She reports the pain as 6 out of 10, denies runny nose, postnasal drainage, cough, sore throat, sinus pressure, wheezing, headache, fever, chills, or fatigue. Mother reports that she's given her Tylenol and Zyrtec and she has no known drug allergies. She's currently on Zyrtec. She has a history of tympanostomy tubes, but nothing else. No alcohol, tobacco, or drugs. Family is all alive and well. No siblings. Her last dental exam was 4 months ago, has not begun menarche, and she denies being sexually active. So she denies fever, fatigue, weight loss, chills, or headache, reports left ear pain, no vision changes, hearing loss, runny nose, no swelling in her feet, no feeling like her heart skips a beat, no shortness of breath or wheezing, no nausea, vomiting, constipation, diarrhea, or blood in stool, no flank pain, no burning when she pees, she doesn't get up at night to pee, no rashes or lesions, no muscle aches, no joint pain, no joint swelling, no thoughts to harm herself or others. So she is at the healthy weight category. She's at the 70th percentile for her BMI. Her vital signs look good, except for her temperature is slightly elevated. Female who appears her acute stated age and has no acute distress. Vision's 20/20. She passed her whisper test. Her left tympanic membrane is bulging and erythematous with a moderate effusion. Her right tympanic membrane is clear and pearly gray. Nasal mucosa is pink. Oral mucosa is pink. Regular rate and rhythm, no murmurs, no edema. Lungs are clear to auscultation. Bowel sounds are present and active, no tenderness, no masses, no lesions. No flank pain noted. Full range of motion in upper and lower extremities. Spine is without lateral curve. She's alert and oriented. She's able to do the duck walk, and she has Tanner stage 2. For anemia, dyslipidemia, ask about sexual interactions or exposure to STIs. Provide anticipatory guidance about menarche. The immunizations an 11-year-old female would need are the Tdap, meningococcal, and HPV. Often you'll have patients say, oh, by the way, during a routine wellness exam, and unless the problem requires additional workup, then you do not need to code for this. Since you would have looked in her ears anyways, this instance did not require additional work, so you would code for the wellness visit plus the diagnosis of the acute condition. Since there's no work, you do not need to add an additional CPT code for this. During the 11-year-old visit, the patient needs screened for anemia and lipoid disorders. She also needs vaccines. Since she's at her annual wellness visit, we do not have an additional code for sports physicals, so this would just be considered under the wellness diagnosis. And so a normal encounter, an encounter for immunization, the acute otitis media, the preventative visit, the Tdap coding, the meningococcal coding, and the HPV coding, and the venipuncture for her blood work. And that is the conclusion of Module 3. I hope you enjoyed it and learned how to effectively code for preventative care visits.